Good morning and welcome to Palliative Care, Bringing It Home, presented jointly by the Alliance for Home Health Quality and Innovation and the Visiting Nurse Associations of America. This session is being recorded. This continuing nursing education activity has been approved for one contact hour by the Maryland Nurses Association, an accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. In order to receive your certificate of completion, you will need to attend this program in its entirety and complete the evaluation available in the conference app. Certificates of completion are available at the registration desk. Our faculty has disclosed no financial conflict of interest. A copy of the full disclosure sheet is available on the table outside the room. I'd now like to introduce today's presenter. Dr. Nancy Gwynn is a medical director at Presbyterian Healthcare at Home in Albuquerque, New Mexico. This group has created innovative programs in home care, palliative care, hospice, and hospital at home. Dr. Gwynn trained in family and community medicine at the University of New Mexico and completed her fellowship in palliative and hospice medicine at Stanford Medical Center. She worked as a primary care doctor in a community health center and as a solo practitioner prior to joining Presbyterian in 2010. She's one of the authors of the New Mexico Medical Orders for Scope of Treatment, or MOST, document, currently serves on the advisory committee for MOST. She's a past president of the New Mexico chapter, American Academy of Family Physicians. Nancy?
Can people hear me okay? Louder? No? We're good? Okay. Hi, welcome. And you're here the last morning of the conference, and you all have planes to catch soon, I'm sure. So I have a program that is overly ambitious because I'm going to try to take you through a description of what we do at Presbyterian, and then somehow I'm going to do a very quick hop and skip through a critical area of training that we've been doing on how to create a palliative care program. So bear with me while I go through some slides pretty rapidly, because my goal is to have a little bit of time to discuss things at the end and to highlight what your particular concerns and issues are. And again, let me know if you can't hear well, because from here everything sounds fine. So I'm the medical director of Presbyterian Healthcare at Home, and I'll talk about Presbyterian briefly and how it has decided to focus on this care. I'm also the director of the Hcc Palliative Care Leadership Center at Presbyterian. Do you folks know about the Hcc? Okay, great. Yeah, so Hcc has identified 10 sites as training sites for people interested in creating palliative care programs, and particularly community-based programs, and so I'm the director of that site there. And the reason I'm mentioning that here is because I've stolen liberally from the curriculum that we developed for our training, and you'll see several slides scattered through here that are Hcc slides, and I want to give them credit since I took their slides. I will let you read the objectives later or prior. So palliative care, I think I'm speaking to a very experienced audience from what I can gather from talking to a few of you, but I always stop and really identify what we're doing. I think it's critical that we identify palliative care as being something that is associated with caring for people with serious illness, relieving the stress of their illnesses, and caring for them throughout a spectrum, a long time, through curative, through at any stage of their illness, because I have really stopped defining palliative care through its relationship to hospice, because when people see the word palliative care and hospice at the same time, they know you're really talking about hospice. So let's talk about palliative care as how we support people with serious illness. That marketing statement up there, which was created by the Cancer Society and Hcc, and that's a shortened version of it, has been shown to be very effective when you talk to patients and families about palliative care. So on to New Mexico. This is one of our house calls physicians with one of her patients. Really, it's just kind of too scenic to believe, isn't it? Presbyterian, why are we doing all of this? I think it's been a very forward-thinking organization, and I've been lucky to be part of it for the last 7 years, because they gave me the opportunity to do things I wouldn't have been able to do in most locations. So what Presbyterian offers is the fact that it is somewhat integrated. It's a health plan, it's a delivery system, it's a medical group. It's not Kaiser, it's not uniform and universal, but it is an integrated system. And they have been very aware of the concerns around values-based care for years, partly because they've been an insurer for a long time. And they've had a Medicare Advantage plan for quite a while, if you think about how long Medicare Advantage plans have been around. So that's really a huge advantage to us, the fact that there is the funding based through a Medicare Advantage plan, and also that I'm I've been working with a group of leaders who are really gotten more and more sharply aware of the need to figure out how to manage total cost of care for all patients. And then New Mexico is just a tremendously poor state. It's a beautiful place, and people there luckily don't define themselves as poor, but we have the highest number of government insured and the lowest number of employer insured patients in the country. The 51 is referring to Washington, D.C., which occasionally gives us a run for our money in the 49 to 51st level of statistics, depending on what you're measuring. So what I often say is that we are operating in the world that is coming for many other states that have a much higher level of commercial insured and still are coasting on a really nice cushion of insurance money that helps underwrite care throughout the health system to Medicare and Medicaid patients. So we have to be very, very sharp on this and very, very lean. And so it's driven a lot of our goals, including a real focus on the triple aim for quite a while now. Here's just a picture of where we are. We're not everywhere in the state, but we're in a lot of places. And I do want to mention that most of what I'm going to be talking about is in that central area around Albuquerque, Rio Rancho, down to Los Lunas, because that region, which covers, gosh, at least 50, almost 100 miles across, holds over a third of the population of New Mexico. So that's where we grow a lot of our programs. And then I'm just now in the process of starting to spread some of these programs out through the state to the smaller regional areas. This is what we do. Our core businesses are home care and hospice, definitely. And core business being the largest home health care agency in the state, which sounds really big until you realize that the total population of New Mexico is only 2 million people. And that our hospice is not the largest, but it's a nice, steady, decent-sized hospice for that region. It's focused on it's a nonprofit hospice. It's the only nonprofit hospice in the region, and then it's also associated with a hospital. So our hospice has very high acuity, very short length of stay, just for background for those of you who are in this business. And then I'll talk about all these other programs, such as our palliative program, our house calls, complete care, our health risks assessment, and the fact that we drive all the advanced care planning for the entire system. I think all of this is palliative in nature. In the field of palliative, we talk about primary versus tertiary palliative care, and I believe that every single one of the people who work in these programs needs to have enough primary care skills to be able to manage and care for their patients appropriately. So we train everyone working with us to some level in that area. So, a real brief timeline. If you think about us starting from the basis of, and I'm going to switch to lavalier so that you don't lose me every time I turn my head. Excuse me for the noise. That'll work better. So if you think about our timeline here, it's either long or slow. I just had a visit from someone training with our Palliative Care Leadership Center who wants all this in a year, and I kind of said it's going to take longer than that. So there's 17 years there, starting from a founding of a robust inpatient palliative care program. Many of you may come from systems that already have that. And then the hospital at home program, we started that effort together with Johns Hopkins in 2008. We've been speeding up in the last 7 years because it was critical to get things done. But I think it's a realistic timeline to think about how long it can take to build robust programs. You're not here to hear about inpatient palliative, but I'll just briefly touch on it. As you can see, we started in 2005. We've revised the program a couple of times. We see now we're up to about 2,400 consults a year in 2 hospitals and 1 skilled nursing facility. And we track a number of outcomes, and each one of these slides will mention a couple things. So in this case, I mentioned we track our 30-day readmission rate. You can imagine why we would want to do that. I drop that information in front of decision makers frequently in any health system. What is your 30-day readmission rate? And then we also track presence of scanned advanced directives in the file for all of our patients. There's an idea, there's a list of members of our team, and then another key point is we have actually grown to integrate completely with our hospice team because patients just don't want to have different people in the room all the time. It's really, really critical to try to integrate and make it more seamless for patients by ensuring they're not seeing different people who, in their mind, are offering them similar care sometimes. So then we I'll talk more about this community-based office palliative program as using it as an example a little later in this talk about how you might do a needs assessment and business planning. But we piloted in 2012. We started with 3 primary care sites. I just did an end run around oncology. Apologies to all of you if any of you are oncologists. But what I mean by that is that we'd spent a number of years knocking on that door, not very effectively. And I said, let's go check with our primary care colleagues who were very, very happy to have assistance with their patient care. And then as time went on and we demonstrated effective care and got to know our oncology group much more, we are now integrated also in the oncology center. They are really very open to our care of their patients. And we actually work together with their social workers and psychologists to form a team for patients. Our home-based program is definitely based in a home health agency. And you know, we can talk about the pros and cons of that later, but I will tell you that being able to get reimbursed for the care is pretty critical to us. So we have chosen not to align our home palliative program with our hospice, but to align it with our home health agency. We tend to have about 1/3 of our patients at any given time on our average daily census of our home health agency are palliative patients. And I can talk a little bit about how they're referred in, but basically we train ourselves to recognize when someone might have palliative needs, or perhaps we're picking them up because they've just been discharged from the hospital and we had an inpatient palliative consult. So our inpatient team is trained to actually refer into our palliative home team on discharge, for instance, from the hospital. And we have very traditional services, you know, our RN case managers, therapy services. We have a fairly robust group of social workers, both here and in our house calls program. And then we also do consultative visits by a palliative nurse practitioner. We do not assume that every single patient on palliative home care needs an in-home palliative consult from a provider. That would be expensive and probably unnecessary. This team is overseen by myself and by our director of our clinic-based program too, and that adds some integration because clinic patients often get home services back and forth. We're aware of all of them because the same people are sitting in on the critical meetings for these patients. And then we do integrate with our house calls program too, to try to give additional support for patients who really need primary care in the home more than they need palliative care providers in the home. This is from our SHP data, and I think this is another slide that I would use in front of leadership to try to demonstrate the effectiveness of a program. So you can see the top lines are our national and predicted acute care, our acute hospitalization rates for these patients. The yellow line is our risk adjusted. The blue line is where our entire home health population resides. So we already in our home health program have a very low rate of hospitalization. And that bottom red line that I penciled in is our palliative care program. So we have stunningly low rates of acute care hospitalization for these patients. And that is pretty well what you want to be able to say to any insurer, any health system, anyone you might be speaking to about creating a program like that, to be able to offer them those kind of data and outcomes as a possibility. I think almost everyone at this point seems to have heard of the Presbyterian Hospital at Home program. It was started together, we're the demonstration project for Johns Hopkins originally, starting in 2008, who founded this program. Many of you have probably heard of Bruce Leff, who the geriatrician there who created this program. And we continue to use the program as a tool in our toolbox in caring for patients. It's not a freestanding program as it was when we originally started it. It's designed to really be for hospital level care of a patient. In other words, these are people who have clear diagnoses that would require them to be hospitalized. And then this slide, just which you can look at later, just talks about the kind of care that they're given on a daily basis. And with all of our other programs, I've just listed a few outcomes measures there because we actually track ourselves against the hospital clinical core measures for success, because that's what we're competing with, right? We're saying that we can give people the level of care that they need and deserve in the home and yet keep them safe and well. So that's hospital at home. Our house calls program actually grew out of hospital at home because there were a lot of patients who did not really qualify for a true hospitalization. and yet needed care in the home. So we started sort of an urgent care visit program with the same doctors, same providers who saw patients in the home. And a lot of it was tied in with our home health population to really help us meet their needs in the home so that they did not require readmission, right? So kind of an urgent care for home health was how we grew it initially. I wrote a proposal suggesting that if we really made a robust house calls program, that we could really affect patients returning to the hospital or needing post-acute care in more expensive settings. And that was sort of one of the agreements from our health system, is that we would make a more robust house calls program. So it's a team-based approach, as is everything that we do, including a pretty robust group of social workers, because I believe they are critical to effectively treating family needs and patient needs in the home, and can be as helpful as any medical provider can be in any of these settings. So here's a few of the things we track. We track our hospitalization and ED rates. We actually do a monthly analysis if everyone goes to the hospital and try to figure out what we could have done differently. We track standard primary care measures because, you know, while I'm not very excited about following lipid guidelines in a 95-year-old with dementia living at home, I do think that it's important that we acknowledge things like influenza and pneumonia vaccines as appropriate and really do care for folks appropriately within that primary care measure. And then presence of an advanced directive is something we track on all of our programs. We've been initiating a transition to care program for this population. Most of them don't go to the hospital, as I've already mentioned, but those that do, we want to get back in the home and manage them very effectively, very quickly. And so what we do is that a year ago we had 72 hours to get in the home. This year it's 48 hours. Next year it'll be 24 hours. We expect our team to actually see patients in the home, do the med reconciliation, and ensure that they're safe and supported. And I think that's just a very appropriate way to treat anyone who you're caring for in home. It's just hard to facilitate. One of the ways we've facilitated it is by working with a community paramedic program. We actually have a contract with our ambulance company, and they are now doing work for us in the home. So they may be doing the hospital follow-up, and they also could be doing an urgent care visit if we can't get to the home ourselves any other way. So that's something to look around, because in a lot of your communities, your ambulance companies are really interested in stabilizing and expanding by building community paramedic programs. It's sort of the newest thing. Complete care, and I'll try to put all this together because these are a lot of different programs. They have a lot of overlays. In my mind, it makes sense, but every time I talk about it, I realize that it's a very shifting paradigm of programs. So complete care is acknowledging that we have a very large Medicare Advantage population. Many of you have heard about programs or insurers in your region who are interested in identifying their high needs patients. And I think that working to serve that need is going to be one of the ways that many of us are able to expand palliative programs and programs in the home. So this is a model where we focused on the 5% of our Medicare Advantage members with the most serious illness burden. And we actually did the numbers. This population was responsible for 50% of the expenses of our entire Medicare Advantage population. So that'll really sharpen your focus when you realize, when you can identify that. So some of your insurers in your area will already have these numbers. Others won't have gotten there yet, but it's an interesting question to ask as you're looking for support. So we enrolled about 600 members, which sounds really small, but think about it. It's we only want to enroll the 5% of the population with the highest needs. And as we expand to the 10% of the population with the highest needs, the return starts to be less and less. I'd like to care for everyone, but I'm very, very practical, and I realize that if I can get funding to do this, this is a great step into caring for patients who have tremendous burden of illness. So we use our alliance with the health plan to fund a bunch of non-reimbursed services, right? We're at risk. We're out of the fee-for-service market. We're no longer struggling here to figure out how to have a $94 payment for a doctor seeing someone in the home cover a ton of services, because now we're in the world of we can give services to patients because the Medicare Advantage plan has acknowledged that they're not worried anymore about the traditional fee-for-service model. So some of what we fund is is RNs who do a ton of in-home case management and actually case manage each one of these patients. We also, for instance, have a foot care nurse, a podiatry-trained nurse who goes from home to home and takes care of any patient with diabetes or anyone at risk of sequelae due to problems with their feet and nails. And that alone is would probably, she's probably has the highest demand services of anything we do, honestly. And it's a non-reimbursed service that we offer. I think a critical part of all of our programs, including Complete Care, is the idea that we have a one number to call day or night. And so it's really been of value to train our patients, who are often people who are desperately calling throughout the system looking for help from primary care, from their specialists, their cardiologists, their oncologists. You can see the list of calls in the medical record. And we retrain the patients and families to just call us, and we'll do what we can for them. And I think that's been a critical intervention that's been effective. And then our Complete Care population is completely integrated with house calls. If you are on our Complete Care program, you will have a house calls provider. Because we think that's critical. And you may need specialty palliative care consultative services, and so if so, we would get someone in the home to help with that also. And I already mentioned the community paramedic program. So this program, we track everything. And we keep figuring out new ways to track things and try to get more and more data from it, because I think it's critical to really understand the results we're having. We worked very hard with our health plan and a data system, and it took almost a year to do this, to develop a total cost of care report. And those of you who've ever looked at this know how hard it is to find how much it costs to care for people. And we were able to demonstrate savings of $1,100 per patient per month in this program. We now think this year it's going to be $1,300. We're about to get new reports out. That, if you start multiplying that, 600 people, 12 months, 1,300, you're talking millions and millions of dollars of savings for a health system who still, therefore, can survive, where a nonprofit system can survive in a very lean environment to continue to offer good care to people. So the cost savings, which I would never be speaking to patients directly about, because the point isn't, the point for them is to get patient-centered care. But I really do look upon the only way our health system is going to survive in the environment we live in is if we can figure out how to offer very, very cost-effective post-acute care to patients. And so this number, is very, very important to the survival of the system. So we have a readmission and hospitalization rate that's about 50% of what's predicted in this population. And then 85% of our patients who die do so at home by their own choice, and they die either on our home palliative team or our hospice team, whichever they opt for. We don't insist that they enroll in hospice if they continue to be adverse to it. So I keep trying to draw models of how these services overlap, and they never quite work, but here's a new version. So here's Complete Care, and every patient's receiving house calls. But home health care, sometimes they need home health care, sometimes they don't, right? They don't, because we have good case management oversight, we don't need them to be on an episode of home health care all the time, but when they need it, they get it. And so there's overlap there, but we also have that freestanding home health agency that also takes care of people who are just gotten out of the hospital with a total joint and need a very minor episode of care and a return to regular care. So home health overlaps Complete Care, but it's not universal. Palliative care. Some of our Complete Care patients need specialist level palliative care, but many of them just need the primary care skills that we've taught the RNs who are case managing them and the house calls providers who offer house calls. But those who do need specialist level care are going to be getting it in the home one way or the other. And then hospital at home is what everyone wants to talk about, so I threw it up there, but it really is a tiny tool in our toolbox. It is something that we can use for any of our patients as they need it. If we're seeing someone at home for an urgent visit because they're not doing well, they're on the cusp of needing to be hospitalized, we can trigger the hospital at home program for that 3-day length of stay, transition them back to a standard home health care benefit to ensure that they get the care they need, and then over time, probably transition them back to just pure old Complete Care house calls. So people move in and out of these programs and services depending on what they need. So from the patient's perspective, I hope they don't see any of those overlaps and they don't hear about all the various ways behind the scenes we're doing things. My goal is that for them, it be seamless and it surround them in a care network. And they may only be aware of 2 or 3 of these people. We're talking a lot about them behind the scenes, but my goal is that they're not aware of all the machines and levers that are necessary to keep them going in these programs. Very brief mention, our advanced care planning program actually supports the entire New Mexico POLST effort. It's just an in-kind contribution to ensure that the POLST really get going in New Mexico. But we have a robust program looking at monthly reports on scanned advanced directives in every part of our system, primary care, hospital, you name it. And my goal, of course, is just to continue to increase access to good quality advanced directives. I think it's a great way to start leveraging basic conversations with patients. So we have training programs and facilitators with the goal of ensuring that people have high quality advanced directive conversations. This is an area many people don't look at. I don't know if you're in your community, if it's worth thinking about, but how many of you have heard about Hcc Medicare Advantage? So Hcc, basically Medicare Advantage plans are reimbursed very similarly to home health on a case mix weight, right? On an index. Everyone's got some sort of, in the hospital it's DRGs, in home health it's case mix index, case mix weight. So the Hcc score, or the RAF score of each Medicare Advantage patient turns into their entire reimbursement. And it is a huge amount of money if a Medicare Advantage population is underrepresented in terms of the amount of illness that it actually serves. So there's been a number of for-profit corporations who are doing nothing but selling services to Medicare Advantage plans for the purpose of seeing patients in the home or the clinic and trying to validate diagnoses on an annual basis that will assist with this issue. Instead, we've taken an innovative approach, and we're actually working directly with our Medicare Advantage plan with a large team of nurse practitioners and PAs. It has to be nurse practitioner PA, cannot be RN, unfortunately, doing this work. And we are seeing patients all over the states in their home for a contracted rate with our health plan, but our goal is actually to do a really valid, useful health assessment and to identify people at fall risk. For instance, we do a fall risk assessment, and then we'll prescribe the Otago therapy program in the home if necessary for them. We're doing really good medication reconciliations, and we're doing cognitive and depression screenings, and we're also working with our health plan on their Medicare star ratings, so we're trying to work on making sure that every person with diabetes, for instance, has a retinopathy exam. So the goal is to also help us identify patients who need our additional care. But this particular program is also a funding stream that helps underwrite our other programs. So it's just an idea. I don't know what your environment looks like. So how do we communicate in transition? There are so many moving parts, as you can gather. One thing is we're lucky enough now, or not lucky enough, depending on how you feel about it. We went live completely on Epic 2 years ago, including our home health and hospice agency. And the end result, however, is that we do have a unified record, and I think that's a critical feature for us. And then we've built a lot of flagging in our system to identify our patients. So there literally is space on the banner for anyone who has an active episode of home health and hospice. No matter where you are, the ER, the primary care setting, the hospital, you can see that this is a patient who has an active episode, so that you're aware that they're in our home health agency and you can appropriately identify them. We also, our complete care patients are flagged, including the number of the office and the case manager, to ensure that everyone gets back to us if they see them anywhere in the system. And then another important area for communication and transitions, I've just made a huge list of meetings there. Meetings take up time, hours, and they're costly. I have not found a substitute for building teams and building good patient care. And so we do invest in team-based, patient-centered meetings. So, and many members of our teams come together in those meetings. So, for instance, our home palliative IDT is a big group by now because our house calls providers come. All of our palliative outpatient providers are there, the home health nurses and therapists who are taking care of these patients. And we use them for 2 purposes. One is a lot of education on palliative care, and the other is actually identifying an appropriate care plan for these patients. So it's been useful to continue to have the meetings. So that was just an example of a few of them there. I'm also wanted to refer to how the teams are blended because I think this is an area that's often confusing for people. Something that's clear in my mind I haven't been able to make clear necessarily to others. So for continuity, first of all, house calls and palliative home care really work extensively together. I mentioned already that the house calls providers are there in the palliative home team, IDT. So sometimes we might see a patient, for instance, in the outpatient palliative clinic first. We determine they have a home health need. We get our palliative home care team in there. And what we're really seeing is they're right at the cusp of not necessarily being able to return to clinic very effectively, or they've been lost to primary care and they're only seeing a specialist. So we might ask our house calls colleagues to assume their primary care role for them. That'd just be one example. Perhaps this is a long-standing complete care house calls patient. The house calls provider has run into symptoms they don't know how to manage or feels frustrated with the process of a discussion. And in that case, what we would do is call in a palliative care specialist to go into the home, often together with the house calls provider, and assist with a palliative consultation. One of our key areas of our team blend that is incredibly useful is that our night nurses cover all of our programs. So we have one nurse on call by phone, and we have another one roaming the community, and then we often have our community paramedics backing that up also. And those folks have really helped us tremendously in being able to care for people who are in crisis at night and ensure that they don't have to call 911 if they don't want to, which I think has been critical. Transition again. This is Abby, who is our medical director of our outpatient palliative program. And what I'm going to do now is just do a very brief touch on a huge curriculum around how to build a community-based palliative program. So 2 days of, when we do one of these leadership trainings, it's 2 days of intensive work in our, as a site visit, and then a year of mentoring. So believe me, this is going to be a very brief look at a few of the factors that are critical. So from CAPC, these are the key principles of community-based palliative care program design. First of all, I mean, if I could just say one thing 100 times, it would be assess your need, assess your need, assess your need. That's when we do our trainings, we find that that is the huge gap. So assess the need and really understand your local environment. Pilot, I'm stopping using the word pilot so much, but the idea is start small. You might want to plan big, but you need to start small. You have got to ensure financial support and collect data to ensure that support. And obviously coordinating care and assuring quality are critical to any program. So looking at needs assessment briefly, I like this slide because it actually separates out two areas. So gathering information, assessing your stakeholder needs. Who are your stakeholders? Pardon? Patients. Yes, first. Patients and community. Yeah. But you also probably have stakeholders in other agencies. You probably have hospital stakeholders. You may have insurance stakeholders. You've got, I mentioned that we created a contract with a community partner, Albuquerque Ambulance, and they were pretty interested in what we were doing and how to work with us. So yeah, assess your stakeholder needs and really clarify why you're doing what you're doing, which includes gathering quantitative data. How many patients are there? Where are they? What are their needs? What does your hospital system need? What are the pain points, which we've already discussed for yourselves and for all of your payers? It's going to be around total cost of care, hospitalization, readmission. Perhaps there's a real fine point there. I worked with a group recently who, it's the congestive heart failure population. They've identified that they're going to work with a cardiologist. And so there's a stakeholder group that's very specific, and they have great data on those patients and what those patients' needs are. And then you're going to use those data to synthesize, decide on your priorities, and prepare what your next steps are for actually building a business plan. I'm going to take a parenthetical clause here around payer structures, and because it's really I cannot separate payer structures from needs assessment in my brain because form follows financing, and I am totally motivated to give care to every single person I can. I've got to figure out how to pay for that, as you saw, that big program. So here's a few of the methods that we've eked out from our system. First of all, we're lucky. We do work directly with the health plan, and our entire medical group and hospital system receives capitation from the health plan, takes in the money and then distributes it. So our service line, our Presbyterian Healthcare at Home group has a small capitated rate that we receive that helps give us a financial base for much of what we do. In addition, though, we get RVU-based reimbursement for our medical group, so that's basically Medicare Part B type billing. We get fee-for-service reimbursement from other insurers, so we're happy to send a bill to any insurance company for having seen a patient in the home, and we do that. And of course, we get our reimbursement for our episodes of care for home health care. We've also just recently developed a monthly per patient per month payment from our health plan to pay for our complete care patients. We calculated the expenses for seeing those patients. We actually added up everything it cost us and identified how, and we're now billing our health plan to underwrite the expenses of the complete care program on a PM basis. And by PM, I mean PM enrolled patient, not a general capitation. And then we have contracted per visit rates that we've also determined from health plan for things like I mentioned the Hcc Medicare Advantage visits that we do. That's a contracted per visit rate. They pay us per completed assessment in the home. So those are just a few methods as we are constantly, as I say, moving the walnut shells on the table and keeping our payment coming in of how we've identified ways we can be paid. This is, and CAPC has some great materials on payment structures, so I'm not going to dwell on this long, but this spectrum is sort of where we're living, and we're basically moving from the left, which I don't think we're going to see anymore, over to the right. So, and it's important to really be able to understand these basic payment structures because it's going to motivate how people are interested in funding your program. So on the left, you see fee for service, no link to quality or value. Gosh, that's hardly any of it left anymore, is there? I think probably hospice, home health episodes, depending on the state you're in, are not yet tied to values-based purchasing, but they will be soon. So very little residing over there, because even if you consider yourself traditional fee-for-service, we can certainly see that a link to quality and value, including the macro MIPS payments that are coming down the line for independent physicians who work with Medicare, are going to be driving towards some measurement of quality and some measurement of value, and ensuring that the care you give patients is of value to them. And then I think Charlotte, on our yesterday morning, talked a little bit about advanced alternative payment models, and that's something we're certainly seeing. An example of that, of course, would be some of the ACO models that people are operating in here, but then also something simple like we're participating in a total joint bundled reimbursement model right now at our hospital, so that Medicare plans on paying us a certain amount for each joint, and it's up to us, our independent orthopedists, our home health agency, our post-acute care folks, to scramble around and be at risk for that payment. So that's an example of a very limited APM. And then population-based payment is really where we're trying to reside as much as possible. So in other words, the Medicare Advantage plan we work with is receiving a dollar amount per patient, and we are 100% at risk. So we must manage that population effectively. So back to needs assessment, because now all of a sudden, I think the payment structure reminds us that one of your stakeholder needs is going to be that they are at risk. So I'm going to just look briefly at our outpatient clinic. I know that home is where we all reside here, but it's just a real simple model to look at for looking at a needs assessment and how you might think about a business plan. So our palliative outpatient clinic, we determined that our health system really wanted to move upstream, and they were tired of inpatient palliative consults being the only way that patients were seen, and they were very appropriate. We felt the same way. They were very aware that readmission and values-based purchasing was lurking in the future, so they were very interested in how we could leverage palliative care to ensure more success for them in the future when they were going to be at risk. Of course, hospital was worried about 30-day readmissions. Our health plan and our pharmacy were really concerned about controlling costs. Our director of our health plan pharmacy benefit is constantly struggling around the new drugs, what are appropriate, what aren't, how to balance needs for patients, what to do with that. And then our primary care and specialty groups needed assistance with complex patients, fear of managing those patients with pain. We've certainly seen that. And also, they just don't feel like they have the time to have real conversations with patients, unfortunately. So this is kind of when we did our needs assessment, this is kind of what we were hearing. And of course, from our patients, what we were hearing is difficulties in navigating a tremendously complex system without assistance. And so that added up to the figures we were looking at. In terms of quantitative data, I actually asked the health plan and we worked to mine their data to identify at-risk patients. And so I was able to predict how many patients we might be able to serve through a clinic by actually looking through the diagnoses of all of the health plan patients and using that information to inform a likely audience for our services. Other quantitative data I've already mentioned. The other thing, when you're looking at how to assess needs and generate a business plan from that, what are your predicted outcomes? How are you going to take that leap of faith when you write a business plan of saying, okay, I predict that we will have a 32% decrease in hospitalization for these patients if you let them take care of me. Well, in my case, when I wrote this plan years ago, I did it on a wing and a prayer because there were only 2 studies I could find nationally. There's a lot better studies nowadays indicating what the outcomes might be. And so I used all of the outcomes research I could find, including the Kaiser study, which is probably 15, 20 years old now, and used it as a predictive model to try to determine what our services would offer, right? What would the potential decrease be? What would the savings be to the system if they would allow me to build this program? So the design that we thought about and worked on was the idea of an embedded primary care site. Again, I know we're home oriented, but it's the same idea. What is your design going to be? Where are you going to house this program? How are you going to house it? What are the nuts and bolts? And so we were looking at how many providers we had. Could we do a half a day per week in the system because the program would mature slowly, so there was no point in having someone sit in a clinic all day every day because we weren't going to see that much volume probably. We decided our model would be a consultation service rather than assuming primary care for these patients, but we heard from our stakeholders, our referring providers, they did not want to be the call coverage for patients on pain management, so we built a call structure in. We already had a bit of a social worker. We had me, the MD. You know, we kind of begged and borrowed from all of our other services, and so that was our staffing model. And then, of course, we started from the beginning talking about how we would track patients in Epic and how we would measure our outcomes from the beginning. So, how does an idea about a program become a business plan? Lynn Spraggins at CAPS, does a brilliant job of saying to everyone, it's English. Don't think about the Excel spreadsheet, the numbers, because most of us are terrified by that. But really define what your services are. How many days a week are you going to be doing this? How many people are you going to be seeing? Who are you paying for what services? What is your likely reimbursement from fee-for-service or from the insurance plans around you? So really just understanding the moving parts of whatever program you're going to build is the critical part of a business plan, and the numbers come last. So the other thing about a business plan is it's actually a critical document that needs to have an incredibly compelling narrative because the people reading it need to understand why you want to do this. And so every system often has a template, so you always want to look for a template for your business plan. But inside that template, one of the first sections is going to be, why are we going to do this? And you want to write it pretty breathlessly and have a sense that this is really, really critical and important. And describe your program in a compelling way. And make sure that you plug in the pieces with the alignment with your stakeholder needs, for sure. So I think I've explained the rest of this. This is just the general concept. In the end, you may end up with something like this as the last pages in your business plan, but the narrative is probably what most of us are good at, and then someone can help you turn them into numbers. So this is very, very old snapshots I took of one of the plans, which just literally was, okay, we're going to have a provider for 5 half days a week. How many visits is she going to do, and what will we recover in fee-for-service from those visits? And also looking at what we expected in terms of savings and variable costs from hospitalization. So very nuts and bolts stuff, but that's the basis of a business plan. So we've already looked at these key principles, and we've kind of touched on assessing the need, maybe understanding your environment. Very little on piloting a program. I'll mention another slide. We've looked at the question of financial support, And I'd like to touch on gathering a bit of pilot and also gathering data. So when we did that clinic, what we actually did was track costs for the patients before and after we saw them. It's a pre-post intervention. It's very primitive. I know, we get into fights about regression to the mean, but it was all I could do at the point to prove the value. But I have to say that everyone sat up and listened and agreed to an expansion of the program when they saw these initial cost savings for these patients. And it has allowed us to fund our expansion. So our pilot generated the data that we wanted in order to be able to grow. We also gather a lot of outcomes data on patients and patient needs. So this is an example of a progress note that we have in our electronic medical record with pain scale, symptom scale. It allows us to generate a report that looks like that. And it says that within X number of hours, someone who we saw who had a high pain score was managed appropriately in those 24 hours. So that's a way of gathering data from an electronic medical record and generating patient-centered outcomes for sure. We also measure what we do, and we can report that out. So there's a list of interventions, So when we see a patient, we do X, Y, and Z, and we can tell you how many times we've completed an advanced directive, participated in a family meeting, defined goals of care. We just keep track of those interventions. We also keep track of our conversations about advanced care planning, and we also keep track of advanced directives. And this report right here on the right actually has a blue area in the middle that shows patient level, it actually shows scanned advanced directives. And if you click on that, the patient's advanced directive will open and you can read it. That's been a critical thing I've been working on for years because I think it's just so vital that these documents aren't just collected, but they are read, they're available, and they are also honored. So we actually do an audit behind the scenes to ensure that our medical orders for scope of treatments are honored in our health system. So many people ask me how we find our patients, and we do it in a lot of different ways. We have direct referrals from case managers in our clinic. We obviously use diagnoses in certain settings and work, for instance, with the oncology navigators to identify and refer patients to us. Our intake staff in home health are great at identifying patients who might be appropriate for palliative care in our complete care program. I already mentioned the annual health and wellness visits. And then we've been working on registries like everybody else. Again, one of our keynote speakers referred to the fact we have got to get into predictive analytics to find patients. And we have been, I think we've now used 4 different data sets to try to find these patients. And we're going on to number 5, which is the Johns Hopkins system. So this is an example of a registry we built using the Charleston Comorbidity Index, which has been refigured for ICD-10 for those of you interested. And it's a list of patients, and it tells me what, it tells me not only what illness that they might have been identified, what morbidity they were identified by, but it also, this report indicates how many times they've been to the emergency room, how many times they've been hospitalized, what's the name of their primary care provider, what visit is, how many, when their next visit is coming up. So it allows us to work our way through the charts rapidly when patients come up on a possible list and identify if they're appropriate and then reach out to them directly. That's been a very rushed presentation. I was hoping that the slides could be used by you as a reference set more than trying to go through every detail because it's a big program. Here's just a few resources. Of course, the American Academy and the Center to Advance Palliative Care. I also put in a reference to a Commonwealth Fund report on our hospital at home model because people are often interested in how it works. There was a recent Kaiser Health News article about home palliative programs that I thought was nice. And then there's a recent publication that actually looks at the financial impact of a home-based palliative program in an ACO, which is, remember I said I was scrambling many years ago to try to find the data I needed to defend the existence of my programs. Well, there are better data now. So, the other reference I wanted to highlight was brand new publication from CAPC, Palliative Care in the Home, a guide to program design, and they've just come out with that quite recently. Well, what's on the list of references is CAPC in general, Center to Advance Palliative Care, and if you go in, can find. I'll turn this off and we can switch to regular mic for questions. You're on there. So, can I answer some questions?
You talked about the majority of your home palliative care was under the Medicare benefit for the most part, or the Medicare certified agency. One of the questions that I had is, I see your hospitalization rate is down, but how does that impact, or has there been an impact on outcome measures? And
Yeah, thank you for bringing that up, because one of the things that, you want me to use the microphone? I know you're recording, so I'm trying to behave. I think talking about palliative care residing in a home health agency, there's a number of key factors, one of which is what's going to happen to us as value-based purchasing really kicks in. And there are a couple of measures in which our patients are not going to do well. And the biggie is functional level, right, throughout their level of care. And we are acknowledging right now that we're going to end up tanking on that measure for our palliative patients. I have yet to see how the landscape will play out for us, and I don't know how critical it will be in terms of our reimbursement. Because remember, if you really validate the case mix weight of your population, then of course the functional decline is more expected. So I think part of it is how are we going to document effectively to really compensate for that, and I'm waiting to see. The other concern that many people have about a home-based episode of palliative care for patients is how often are they going to fall off the episode? So are they going to end up on the on-off, on-off? Most of the palliative care patients that I see really qualify quite well for assessment, observation, management of medication symptoms because they are really ill. And so I don't feel that it's difficult to continue to certify them in home health, and that's been less of an issue. The homebound issue also, most folks are very appropriately homebound. Luckily, because a good percentage of our patients are also Medicare Advantage patients, we can negotiate around any of those restrictions. And so that's why I was kind of saying, look at your whole environment, and if you're going to build a pilot, try to build it with a Medicare Advantage plan, because that will give you the space you need to really define some good models of care. Did that answer your question?
Just to continue on that, can you comment a bit on the overlap of services? We're looking to launch and have a health plan, have a physician group, have post-acute care, and it's a challenge to take a look at how the overlap can be managed effectively and most efficiently. So I loved your comments.
Yeah, we have a special care transitions team that was just built by our hospital system that we don't manage, that is following certain patients for 30 days. And what we've actually done with them is just go in and partner with them and say, don't lose track of these folks. We've made them very aware of our complete care program and the other programs we can offer. And we're now building some more seamless transitions with them so that people don't end up being seen by more than one person. And in addition, that complete care flag that we have for our patients, that they pay attention to that. So if they see that come up in the hospital, or this is a patient who would normally get a transition of care 30-day episode from their team, if it's complete care, we have reports that identify those patients. We're aware they're in the hospital. We can communicate back and forth about them. But yeah, it is so nuts and bolts to have to to look at that whole spectrum of care transition and try to figure out where how you fit the pieces together. And it does take a ton of work. I think mapping out all those services and avoiding duplication is critical. So lots of work and lots of negotiation with everyone.
Thank you. So my question is regarding the payer sources, and I appreciate the slide that had, 3 or 4 different revenue streams. So can you give us an idea of what percentage you get from the PMPM, what percentage for fee-for-service, and then what percentage from, I think, home health episode, and there may have been another one there. And then have you done an analysis of the cost of those services versus the revenue of those services? So bottom line, do you break even?
Bottom line is, because of the capitation that our entire department runs from the health system, we run a positive margin. And that margin goes straight back in the health system. What I say that my job has been for the last 7 years is to erode our margin. So when I first arrived, we were a home health agency with some inpatient palliative services, and then everything else that was up there has been built since then with the partnership of my administrator, Carrie Decker. And our margin has gone from very positive to slightly positive. But the system, that's how the system is allowing us to exist, is by allowing us to erode a margin that used to contribute back a lot more. I was struggling when you were asking me to name all the percentages, and I don't know if I can do it because the cap actually comes in and underwrites all of our entire department, including our full home health agency, our administrative services, our inpatient palliative, and our hospice. And so what I think the cap, and I'm going to just take a wild guess, I think the cap is probably underwriting 20% of our services overall for our entire service line costs. That would be a rough guess. In terms of specifics that might be useful to you, the house calls program, we've tracked the expenses of having a freestanding fee-for-service house calls program with the hospital at home component. And our fee, if you built it with a fee-for-service reimbursement model, you would basically your fee-for-service component from seeing all these patients in the home would underwrite about 50% of your costs. So you've got to find 50% elsewhere. And that's the costs of having schedulers and virtual clinic people behind the scenes helping your docs, maybe an RN to manage patient calls, and then, of course, the salaries that come from physicians and social workers and nurse practitioners. So that's, I'm sorry, I can't get more specific than that. So productivity, we're asking house calls provider, we're in a pretty rural area, so I think you could do a little better in other areas. And none of our patients, almost none of our patients are in assisted living centers, so if you have, if you can see patients in facilities, then you can talk about 10 to 12 visits per day. And most private house calls docs nowadays, that's what they're really doing. But what we do is drive to homes. And so our productivity is around 5 visits per day, plus all of the other background work. So it's low, but that would, yeah. Well, it's, it's constant effort. Gets me in trouble with my providers.
One of the things you talked about was the clinic, the palliative care clinic in relation, and then I was just interested if you could speak to how you coordinated the palliative care clinic and, let's say, your home-based palliative care, and how those two teams work together. Mm-hmm.
So one of the ways we coordinate is that we are behind the scenes actually pretty close to the same team, and all of our clinic providers, including myself and the 2 full-time nurse practitioners who are now doing clinic as of next month, sit in on the home palliative team meetings. We are the attending of record for a lot of those patients. And of course, any of you in home health know that a nurse practitioner cannot be the attending of record, nor can she sign any orders. So I co-sign a ton of orders. But all the nurses know that Abby, the nurse practitioner whose picture I showed, managed those patients. So we assume responsibility for them. The other interesting coordination that we've developed is we really wanted to have a social worker in the clinic, like in the primary care setting, but it's just too expensive to have 2 people sitting in a room with each patient. So instead what we do is we do a medical visit for our initial evaluation, and if someone needs social work, we actually ask the home team social workers to see them in their home. So there's already that blending. Overall, our social work team with inpatient palliative, house calls, home palliative, hospice, 5 social workers in hospice, we have about 17 social workers in this program, and probably close to 25 providers, so that gives you the ratio. One more question. I warn everyone out.
I just wondered if you use a predictive modeling tool at all to identify patients that were appropriate.
So we're about to test the Johns Hopkins ACG model, and we're actually testing it against our complete care program because we know the outcomes of those patients. So they're a perfect test population. Before this, we had a data company that was interested in developing a model they were going to market. So we fed them all our Presbyterian data. I actually sat with one of our, another version is I sat with one of our statistical analysis and actually tried to figure out clinically what would identify patients. And we ran that model, and then now the Charleston Comorbidity. So we're on our 4th pass for a predictive model. And none of them are perfect. And I'm actually really curious to see the outcomes from the Johns Hopkins database, because I don't know what that's going to do. I don't know because I haven't seen the results yet, but their risk stratification looked like it was really sophisticated. And so if it turns out to be so, I'm going to be excited, but I'm waiting to see. So far, the Charleston Comorbidity has been as good as anything that we've done, the newest version of it. And we're pulling data not just from diagnoses, but from the medical record, which is critical. I will tell you that when this big-time data firm came in and spent a month churning our data, and triumphantly announced the results, guess what? Oxygen use and albumin. And don't we all know that already? I mean, it was nice to have a statistical validation that an albumin is basically the palliative lab score that is most critical. But their list, which they were really excited about, was something that was pretty basic. Yeah.